Aloha mai kākou. I am Dr. Kauʻi Baumhofer. I'm an assistant professor of Indigenous Health Sciences. You guys all give me a thumbs up, whoever's on video, a thumbs up if you can hear me and see me. No? Okay. Thumbs up. Okay. All right. Glad you're still going. Mom is not sure. Mom's giving us stuff. My mom, Auntie Jackie, is here. My dad is here too. Okay, so as I was saying, I'm Dr. Kauʻi Baumhofer, and I'm an assistant professor of Indigenous Health Sciences at University of Hawaiʻi, West Oʻahu. So I want to say, first off, mahalo to my fabulous colleague, Dr. Kamuela Young, who organized this COVID speaker series very quickly. He emailed all of us last week and said, "Hey guys, let's put this together. You know, we've got a lot of great thoughts within our little health sciences subdivision, and let's talk to folks and have some conversations." So we all kind of volunteered, and there's a whole series of us. So if you've probably already seen the UH West Oʻahu COVID-19 library site, and that has a list of everyone who's doing talks this week. I believe they should all be recorded. I'm somewhat new to Zoom, so I think it's being recorded. It should be put on YouTube afterwards. And I'm also unsure of the status of sharing slides, but library at UH West Oʻahu, our librarian is saying, yes, it is being recorded. So I'm also not sure if we're going to be posting slides, but if you're interested afterwards and you'd like a copy of my slides, my contact information will be on the last slide of one of the last slides of the presentation. So I wanted to get started with my talk today. I'm going to go until about 12:25 or so, and then we'll have room for a couple of questions, and then Dr. Lynette Williamson will take over, and she will be talking about some health policy. So the title of my talk today is "Pay No Attention to the Man Behind the Curtain." If you are sharp, you might be able to catch that this is a reference to The Wizard of Oz. And so we're going to be talking about the social epidemiology of COVID-19 and racial and ethnic health disparities that are being sort of revealed from this pandemic. We're going to cover 4 topics today. Number 1, who's being affected most by COVID-19 infection? Number 2, what is a health disparity? Number 3, where do these health disparities come from? And number 4, what can we do to address some of these health disparities? All right, so first, who's being affected most by COVID-19? So this is just a kind of small example of some news articles that I've collected over the past couple of weeks that have really stuck out in my mind. You know, on the left side, there's been a couple of really great Civil Beat articles talking about how Pacific Islanders and Native Hawaiians are dying at higher rates of COVID-19 or getting infected at higher rates than we would expect given their relatively small numbers within the population. African American and Latino people are dying of COVID-19 at much higher rates than we would expect all over the country, in California, in the Northeast, as well as the South. My fiance just shared with me a news article a few minutes ago. He was telling me, I think it was North Carolina, where in a certain county, every single person who has died of COVID-19 is African American except one. And that's very striking and concerning. So we have, some political pressure from the CDC to release this data. There was a while there that this data was not being released. It was, just not really being thought of, and now it's being pushed out into the public. So fact, serious COVID-19 illness is affecting racial and ethnic minorities at higher rates than non-Hispanic whites. So the COVIDNet surveillance system, which stands for the COVID-19 Associated Hospitalization Surveillance Network, conducts population-based surveillance for laboratory-confirmed only COVID-19 hospitalizations in 99 different counties in 14 different states. And so while this is definitely a subset of the number of counties in the United States, they were purposely chosen to be fairly representative of the demographic breadth of our nation. So within this COVID net catchment area, there were a total number of 9,483 hospitalization reports that were collected, and between March 1st of 2020 and April 18th of 2020. So out of these cases, unfortunately, race and ethnic data was only available for 30% of cases. So it's a really low rate, and there's a whole bunch of reasons why we can think about what the cause of that is. But I just wanted I made this little infographic last night to kind of show some of the disproportionate burden on African Americans, especially in the COVID-19 pandemic. So the top little area there is, I think you guys can see my cursor. So this top area shows there are about 50 within the larger COVID net catchment area. Approximately 59% of the residents in those counties are identified as non-Hispanic white. About 18% identify as non-Hispanic Black, and so there's two little people down there, and about 14% of individuals living in this catchment area identify as Hispanic, either Black or white, and 9% are other, so that's including Asian, Pacific Islander, American Indian, Alaska Native, and anyone else that you can think of. So then when you look at those individuals who've been hospitalized, who reported hospitalization via the COVID net surveillance system, we see that there are disproportionately fewer white individuals. Only 44% of the hospitalizations are non-Hispanic white, whereas 31% of COVID-19 hospitalizations gathered by the COVID net system are African American. We see the Hispanics and others are slightly proportional, so with 12 and 13% respectively. So fact number 2, individuals with underlying health conditions are at much higher risk of hospitalization from COVID-19 complications. So from the same COVID net hospitalization data, we can see that individuals who reported hospitalizations have 92% of them have an underlying health condition. And so that ranges from a low of asthma with about 12% and a high of hypertension, which is about 56% of individuals who are hospitalized with COVID-19 related illness have hypertension. We also have high rates of cardiovascular disease, chronic lung disease, metabolic disease, and obesity at just over 50%. So down at that bottom line, we see that only 9%, 9.2% of hospitalized individuals in this surveillance system do not have a known health condition. So this is a very, very high risk factor for serious COVID-19 disease. So fact number 3, racial and ethnic minorities have higher rates of these underlying medical conditions compared to white Americans. And so I went through some health disparities reports from the CDC last night and created this little infographic here. And so the numbers are, you can reference the numbers right here with my reference slides if you want to read the whole report. Very long. I'm not sure if you want to do that, but it's there if you want it. So starting down here in the bottom right with obesity, so both, and I'm just going to focus on national data, looking at African Americans and Hispanics, comparing them to whites. And the reason why I'm doing this is just because there's more national data available, but I'm not including Asians, Pacific Islanders, Alaska Natives, Native Hawaiians, and American Indians, because in a lot of the national data, there's simply not enough of those people to make any sort of statistically meaningful comparison. So just focusing on the 3 main ethnic groups in America right now. So non-Hispanic Blacks, non-Hispanic whites, and Hispanics. So down here at obesity, Blacks and Hispanics are about 1.1 times more likely to be either overweight or obese. The clinical definition of overweight is having a BMI of at least 25 to up to 30, and then being obese is having a BMI of 30 or above. This is seen as a significant risk factor for serious COVID-19 illness. Metabolic disease, so both Black and Hispanics have about 1.6 to 1.65 times more likely to have some kind of metabolic disease, prediabetes or diabetes compared to white. Asthma, Black children are nearly twice as likely to have asthma compared to white children, whereas white and Hispanic children have approximately the same risk. So this is something that is interesting. I am not an asthma expert, so I'm not 100% sure as to the reason for that. My focus is mainly in obesity and diabetes. So hypertension, we hear a lot about African American disparities in hypertension in the medical movement, in the medical field. This is a very well-known disparity, and so African Americans are about 1.5 times more likely to have hypertension than whites, whereas Hispanics and whites have approximately the same risk. And part of this might also be due to some age differences in the different populations. Now, in cardiovascular disease, I saved this one for last because this one was really interesting. So when you look at in these large national surveys, the researchers will ask participants, do you have cardiovascular disease? Has a physician or a health professional ever diagnosed you with cardiovascular disease? And then you either say yes, no, or I don't know. So the prevalence of African Americans, the proportion of African Americans and Hispanics who say that they do not have heart disease is actually lower compared to white Americans. However, a large part of the reason is because Blacks are less likely to survive their initial heart attack or stroke. And so that's why we see, we have to actually look at the mortality data to understand the scope of this disparity. So we have less survivors, more African Americans dying of their first heart attack or their first stroke, and so less are able to survive to say, yeah, I have heart disease. So that's why there's this really interesting statistic here, and from the previous slide, we saw that heart disease was a significant factor in serious COVID-19 disease. All right, so bringing it home to our Native Hawaiians and Pacific Islanders, preliminary local data, as we saw from some of those newspaper articles in the first couple of slides, preliminary data from Oregon and California is showing that Native Hawaiians and other Pacific Islanders are shouldering a disproportionate burden of serious COVID-19 illness and death. Interestingly enough, however, Hawaii's data is not really showing those same major disparities in COVID cases, except that Asians are actually underrepresented in COVID-19 cases in Hawaii compared to what we would expect based on their demographic proportion. So, looking at this graph, we see, you can see my little pointer here. So the green bars are showing the proportion of cases in Hawaii, COVID-19 cases in Hawaii, and the proportion by ethnicity or by race. And then the proportion, the gray bar, is the proportion that group makes up for the total state population. These horizontal bars right here are basically telling us whether this difference is statistically significant or not. If the horizontal bars cover both the tops of both bars, then that means it's no different. We don't have any more or any less cases for that ethnic group or that racial group than we would expect based on how many of them there are in the population. So you see the Asians are actually the only ones who have any statistically significant difference. And they're actually underrepresented. So there's a lot of different things reasons why we could speculate as to why some of these results and patterns are different from what we're seeing in California and in Oregon. And we may see some different patterns emerging after further analyses that take factors such as age and underlying health conditions into account. So we need to remember that these are very preliminary, results and very early results that we're looking at from our state. All right, so want to circle back to the title of today's presentation, which is a reference to the man behind the curtain in The Wizard of Oz. And in this metaphor, COVID-19 is a curtain that's being pulled back and is revealing the underlying driver of the racial and ethnic disparities in COVID-19. To go further into the metaphor, the man at the controls represents the social, economic, and political root causes of existing health disparities in American chronic illness. All right, so number two, what is a health disparity? I've been throwing this term around, and it's a bit technical. So I want to start with a pretty graphic illustration, but non-technical definition that Dr. David R. Williams, Department Chair of Social and Behavioral Sciences at the Harvard T.H. Chan School of Public Health, likes to tell. So Dr. Williams is a world-renowned sociologist who is arguably the world's expert on racial and ethnic health disparities. He also happens to be my much beloved doctoral advisor, and a man that I really respect and enjoy, spending 4 years studying under. So he uses this example a lot to illustrate the depth and the urgency of racial health disparities in America. So he says, imagine a fully loaded jumbo jet with 265 passengers and crew taking off from the Toronto airport and everybody on board dying. And that happens today and tomorrow and every day next week and every day next month and every day for a year. And so, while we might think 265 individuals a day slipping away relatively quietly from, diabetes or heart disease or cancer and the likes is easy to turn a blind eye to, it should still be considered an outrage and deserving of more attention from both the medical system and policymakers. All right, so now I'd like to turn to some very technical definitions of some important terms that are necessary to understanding the roots of and the potential solutions to racial and ethnic health disparities. So first, a disparity is simply a number or quantity that separates a group from a reference point on a particular measure of health that's expressed in terms of a rate, proportion, mean, or some other quantitative measure. So all of those words basically mean that if we've got 10 folks in one group and 10 folks in another, and one's got higher rate of disease than the other group, that difference in the numbers is the disparity. But one of the issues with that is there's no attribution to the difference, to the root cause of that difference. So why is there a difference? If you've got two groups of people building, let's say, a table, and three of them in one group get cuts or splinters or something, and have need stitches, and then you've got 7 people in the other group, like you might stop and think, gee, why are 7 people in this other group getting hurt versus only 3? Maybe they have better access to protective resources. Maybe they have better tools. Maybe they have, some kind of better training on how to use the tool safely. So that's kind of where we get into the definition of an inequity. So an inequity is a difference in the distribution or allocation of some resource between the groups. So that would be, in this example, education, training, protective equipment. Maybe one group is able to sleep more and has paid sick time off, so those kind of inequities. So an inequality is basically a disparity with an attributional root cause that is related to an inequity. All right, so to flip that on its head, I want to also give a quick definition of health equity, which is what we're trying to, strive for. So a health equity, and this is from the CDC Health Equity Working Group in 2007, is a fair distribution of health determinants, outcomes, and resources within and between segments of the population, regardless of social standing. All right, and then that pulls us into topic number 3. Where do these health disparities come from? As I illustrated with the little construction example, the difference in 7 versus 3 injuries in the 2 groups doesn't just come from nowhere. It doesn't come out of a vacuum. There are underlying reasons for why one group is experiencing more injuries than another. So the short answer is structural inequalities. However, the longer answer requires a little bit more explanation. So Nancy Krieger, Dr. Nancy Krieger, is a professor of social epidemiology and developer of the eco-social theory of disease distribution. She recently did a really interesting interview with the New Yorker magazine on the root causes of COVID-19 health inequalities. So she says what the virus is doing is pulling a thread that's showing how many things are actually connected and how deeply people are actually connected. But it's also revealing the very different conditions in which we live because of social structures that are inequitable, both within the United States and between countries. By pulling the thread, it's revealing patterns that have been long known in public health. So again, we have this metaphor of the COVID-19 pandemic being a revealing force for deeply rooted inequalities in our society that are embodied and then result in unequal burdens of disease. And I'm gonna give you a full lesson that I give my students on day one. So this model is showing the socio-ecological framework. And so the socio-ecological framework was developed by Uri Bromson-Brenner many decades ago. And also the eco-social theory of disease distribution developed by Dr. Nancy Krieger they make a very similar point that we literally embody the environments we're a product of, and these environments are reflected in our states of health. So to begin from the outer layer, of this onion, I like to plot with my students and say, okay, what's the real name of the onion model? Then they think, oh, socio-ecological. So the onion model is our political, social, physical, and economic environment are engineered based on societal values. So over the course of the 18th to the 20th centuries, the United States was largely built on the trilogy of ideologies that included Christianity of its time. I want to be specific; these are all historically contextual. Capitalism and racism. So the modern day consequences of these ideological foundations include deep structural inequalities that privilege certain racial groups to access to health promoting resources over other groups. For example, residual racial residential segregation, which is the idea that Blacks live in one neighborhood, whites live in another, and Asians live in a third neighborhood. And this is institutionalized and reinforced by practices such as redlining. So these deep racial residential segregation, residuals are they don't just determine your zip code that you were born in or that you live in, but also your access to education, your access to well-paying jobs with desirable benefits, social norms surrounding smoking or other unhealthy behaviors, and exposures to environmental toxins. So these environmental factors down in this layer here help to engineer the behaviors of family units and individuals. So in unhealthy neighborhoods, poverty can lead to hopelessness. The stress of constant everyday racism contributes to the premature internal aging of Black and brown bodies. Particulate air pollution is embedded literally into lung tissue, and ultra-processed foods are consumed and stored as excess fat. Sugar consumption promotes inflammation, which is the pathophysiological basis of atherosclerosis, diabetes, and other chronic illnesses. So, to sum that up, these two models are basically saying we live within a political, societal, and cultural context, which then creates our physical environment, which then helps to push our individual behaviors in one way or another. And that ultimately is embodied literally in our tissue, in our body, and comes out as manifest as disease. So that brings us to our last topic. Now that I've all bummed this out, we need to ask why. What can we do? So the good news is that where there's a problem, there's always a solution. So luckily, we have a homegrown theoretical model that can guide us to several good solutions that can address some of the root causes of these health inequities. And so I want to introduce you to the LOKAHI triangle. So this represents, this diagram represents kind of three apices of, the powers that be, whatever you might want to call them, our earth, our land, our water, and our people, our community. And so this model really shows the interconnectedness between these three elements. And I think, throughout the past few weeks and in the coming months, we have a really incredible silver lining to have an opportunity to start to envision how our society might be better, and also to have the courage to act. Everything is shut down right now, and we will be rebuilt after this pandemic, sort of passes and we start to open up again. And if we don't have a voice in how things will be changed, society will be rebuilt either by people who either don't have our best interest in mind, or by at least people who don't have our perspective. So it's really important. So there's three kind of things that I think we can take from this model. It says, first of all, take care of each other, take care of our community, prioritize the people in our community, especially the most vulnerable. Make sure that our keiki, our kupuna, the houseless, and those with behavioral health challenges are taken care of and can live lives of dignity and safety. Perhaps we should create a public-private partnership to transform some of the cheaper apartment-style hotels into kupuna elder housing, or to house residential behavioral health programs. In the past years, we've seen that per capita tourist spending has declined, especially on Oʻahu. So we're getting a lot of low-value tourists who are not providing that extra capital into our economy like they used to in the 80s. So let's use some of those resources to benefit our own communities rather than low-value visitors. We can, in that same vein, pivot our economy from one that serves 10 million tourists a year to one that allows Hawaii's people to serve themselves. So if we retrain workers, we are, direly short on home health aides, certified nurses aides. We have a teacher shortage. We have, farmer shortage too. One of the three main barriers to farmers are access to land, access to capital, and access to labor, to reliable labor. So have a program that helps to retrain people into jobs that will serve our people rather than visitors. Also, invest in high quality public education. Prioritize our keiki with high quality preschool and programs that support intergenerational learning to show our kupuna that they're still valued and still have a lot of wisdom to pass on to our younger generations. My mom Auntie Jackie is a frequent visitor to my classroom. She's a frequent visitor to UH West Oʻahu, and it's I love having her in my class. It's really a great honor to be able to teach with her and have her be a part of my class. Number two, take care of the land. So in Hawaiian culture, the earth is Papahana Mokuakea, our mother. The sky is Wakea, our father. Treat them as such, not as commodities to make money off of. One idea that I had was if Mayor Caldwell has an initiative to plant 100,000 trees by 2035. What if 10% of those were ulu trees, were breadfruit trees, and we had food that we could give to some of our vulnerable populations? Also, that kind of blends into creating and maintaining a robust localized food system based on minimally processed healthful foods. So one of the most important things that this pandemic has taught me is that there's food here on this island, but too much of it is leaving our islands, is going to the hotels and going to the restaurants and leaving our islands. And we need to help farmers, help to incentivize farmers to prioritize local families as their customers rather than hotels and restaurants. And also to incentivize local families to buy local produce rather than relying on imported foods from Costco and Sam's Club. And also to support our farmers, again, in the three largest barriers: capital, access to capital, access to land, and access to labor. So, we also need to keep working towards Hawaii's goal of 100% renewable energy by 2050. This is really hot button issue. Nobody seems to want large-scale solar. Nobody wants geothermal. Nobody wants hydroelectric, and nobody wants wind power. So we need to, as a community, figure out what we want to do. Talk to your friends and your family and your neighbors. Then show up at a neighborhood board and make your voice known. Better yet, fill one of the vacant spots on your neighborhood board. I've checked in my district of Aiea. Sorry if there's an ambulance going by. I live about 4 blocks from Queens Hospital. And so check if there's vacancies. I've checked in my neighborhood board. I made my students check if they have vacancies on their neighborhood board. So again, no vote, no grumble. If you're not involved in this process, don't complain when things don't turn out the way that you would like. Lastly, protect our sacred spaces, not just for the well-being of Indigenous Hawaiians, but for the well-being of all Hawaii's people. There's some places such as Mauna Kea, that are so sacred that they just need to be left alone. Their steady and really unchanging presence can give comfort and stability in a very unstable world. So lastly, to hit that top apex, you know, be connected with the life force that binds everything in the universe together in order to build empathy as a life practice. I think, you know, that underlying value, ike kupuna, of aloha, and to remember our responsibility to one another, remember our responsibility to our earth and our sky and all of the other living beings, is probably our #1 resource that we have here in Hawaii to not only address root causes of health inequalities, but to rebuild after this pandemic. So I went a couple of minutes over, but I wanted to say mahalo, malamu pono. If you have any questions, you can be in touch. This is my email, my phone number, LinkedIn, faculty profile, and a podcast I did while visiting Mauna Kea this summer on intergenerational historical trauma. If you want to check that out, and mahalo. So I also have references for all of the sources that I cited in my slides. So that takes care of my portion of the presentation. Does anyone have any quick, like, 2-minute, you know, one or two questions before I pass off to Lynette? Okay, one question. So UH West Oahu is, the librarian is texting me that one question that was sent in: why isn't there a better way to provide for a breakdown in healthcare statistics by ethnic and racial lines to show where the system is falling short, why it's falling short, and where funds need to go to bring things to a more equal footing? That's a really great question. So I think it's kind of twofold. One of them has to do with statistics. Sometimes there are not enough people in a certain group to make any sort of statistical conclusions. Like their numbers might be all over the place. There's also privacy issues. So we get into this we see like with infant mortality. So there's so few cases of infant mortality that, you know, if you look on the Hawaii State Department of Health, you know, the website, the IBIS website, all the data on it, and you see, okay, there were 2 babies who died under the age of 6 months, and they are ethnically Filipino. Like, that's a small enough community that you might know who that is. And so we want to, part of the reason is if it's such a small community, we want to protect patient privacy. Also, that's not enough numbers to really draw any meaningful conclusions. So sometimes, like, well, that's why I didn't include the Asian and Pacific Islander, Native Hawaiian, Alaska Native American Indian statistics when I was talking about the health disparities with the infographic. There's just not enough numbers to really come to any good conclusions. All right, so a second question that was submitted is are there any gender-based data available? News reports have been indicating that more men are infected and dying. We've been hearing that chromosomes and hormones might play a role in this. Do you have any insight into the role of gender in this regard? Yes. So number one, there is gender-based data available. I didn't really include it in this presentation because I needed to be really brief and concise. But there is gender-based data both at the national level and at the local level. So if you go into my sources and you look at the COVID-net data as well as our Hawaii data, you can kind of mess with their interactive charts there and see that there is you know, some differences. Just anecdotally looking at the mortality cases here in Hawaii, most of them seem to be men. I haven't looked at that data, but it does seem, all right. And so, you know, there is some talk. I'm not a physician. I am a social epidemiologist, so I don't know a super lot about sex differences in chromosomes and hormones, although I have been reading some reports that our X chromosome is linked to immune response, and since women have 2, we might have a stronger immune response, and that there might be some role of estrogen in the immune response. But I am not an expert in that, but it seems that there might be some relation. Okay, Vera is asking, can you share the links here? Yeah, I will pass things off to Lynette so she can start her half of the presentation, and I will find those links and chat them to everyone.
Thank you everyone for attending. This is the fourth, I am the fourth speaker for this whole series. So there's 7 of us. So thank you for coming. I know there's a lot of information about the pandemic. So I do appreciate your time. My focus is going to be on healthcare delivery changes and some of the policy issues. Just a couple of disclaimers. I am not a physician, so I can't answer any clinical type things. My area is health information management, and a lot of this information I'm sharing with you is things that have happened recently, and it could change moving forward. So at the end, I'm going to talk about some of the health insurance policies. And so I'm going to specifically highlight some of the health insurance carriers here that a lot of people in Hawaii have, but there could be more carriers. And I know we have a diverse attendance here today. So I may not talk about your particular health insurance policy. So you may want to look at some of the resources that I will provide so that you can research perhaps your individual healthcare provider if you need to do that. This is our agenda for today. So I am going to talk a little bit about the healthcare delivery from the aspect of what we may be hearing a lot about, which is telehealth, and how that is being used currently under this pandemic, and the impact that it is having, or the impact that the CARES Act has specifically on telehealth. I'm also going to give you some background on telehealth and telemedicine, because I see a lot of the media is using those terms as synonyms, and they truly aren't synonyms when you look at the definitions of those words. And then I'm also going to then move to talking about HIPAA, which is the Health Insurance Portability and Accountability Act, and talk about where we were in terms of before pre-pandemic and where we are now because of the sharing of information, sharing of people being positive, and then sharing that their name and their address so that they can do the tracing, the contact tracing. And then again, as I stated earlier, we're going to talk about a little bit about the insurance providers and what they're doing in terms of their policy changes, because the HIPAA policy is a federal policy that covers all of the United States, and individual insurance carriers that are non-Medicare, Medicaid would be those individuals that can make their own policies. And a lot of that has to do with the cost that we may incur as a patient if we are diagnosed or being treated for COVID-19. Because as we know, most of our health insurance, even if you have health insurance through your employer, typically there's a copay or deductible or both that you have to pay in addition to what your employer is giving you. And then finally, just I have a listing of my references and my contact information. So just to identify that a lot of states are still under a stay-at-home order or shelter in place. There's supposed to be no non-essential travel. Many states have also stopped their elective surgical procedures. And so, but what happens with those individuals that Dr. B just mentioned in our communities that are suffering with chronic diseases such as diabetes and hypertension? Typically, those individuals need some type of 3 to 6 month check-up visit. They may need medications refilled. They also could be experiencing some other issues such as not sleeping well, anxiety is increasing, so they may need some adjustments to their medication, so they can't just forego perhaps, or shouldn't forego perhaps, a visit to their physician. So what's being said is that they should be using telehealth, right? That's kind of where telehealth could potentially fill in the gap. And so especially if they have a chronic issue, or perhaps they have a new issue, but they are a chronic patient, but they already have a relationship with a physician. But just again, to give you some background in terms of the terminologies that you may be hearing in the popular media, the first word that you might be hearing is the use of the word telemedicine. So per the World Health Organization, telemedicine is defined as the practice of using technology to deliver care at a distance. It was first identified by the World Health Organization to be used in the 1970s with the focus of 4 specific goals. And you can see those goals here on the slide. And it really is, telemedicine is focused on clinical support and hopefully to improve health outcomes and overcome particular barriers. It, however, is often being used now as a synonym for telehealth. Per the US Department of Health and Human Services, telehealth, however, is the use of electronic information and telecommunications technologies to support and promote long-distance healthcare. So the key here, I think, when we look at the difference between the two, is that one is more clinical focused and the other one is more broader. From a history, telehealth has been around for a long time. There's been some identification in the popular media that it's a new thing, but it is not a new thing. Research has shown that it started back even in the 1800s, 1879. There was an article that was published in a medical journal talking about using the telephone. And in the 1920s, telehealth was used on ships to give more information to the clinical health providers. So pre-COVID-19, we were using telehealth to some degree, and I will give you some background information on a research study that was done in April of 2019 to give you some ideas of where we were, and then moving forward, we can see where we are post-2020. There are other variations for telehealth, specifically things that are already happening and that were happening before the pandemic that you may not have been aware of. There's teleradiology, which is the digital capture of radiology film, radiology imagery. So instead of using films, they digitally capture those and then they can share those across systems, across the country, etc. Telepathology is kind of a growing area. It can be cumbersome, however, there's a challenge with telepathology specifically because of the size of the files when they're trying to transport them across systems or across from one facility to another. And then telepharmacology is one you have probably already seen and used, because when you go to a physician now in 2020, before all of this happened with COVID, most likely if you had a prescription, even if it was a refill, it was sent digitally to your pharmacy. And that has been in place for a while, and that process is called computerized physician order entry. So that's one that is really widely used in the United States, is telepharmacology. So the difference again between telehealth and telemedicine is that telehealth is a term that is more focused on non-clinical activities. So telehealth can be used not just for interactions between a physician and a patient. It can also be used for things such as clinical training sessions for physicians or for continuing medical education. Most individuals working in the healthcare arena have to continue their education even once they graduate and once they're out practicing. So telehealth is a way that physicians and other clinicians can still continue their medical education. Telehealth also includes things like video conferencing and using radiology, as I stated earlier, and wireless communication. So here is the information on what was happening previously. So in April 2019, a company called M3 Global Research provided some information. They also did a survey of physicians in 2018. So as of April 2019, before COVID, 1/3 of hospitals were using some type of telehealth, and 45% of outpatient facilities. So it will be interesting to see how those numbers change moving forward. And right now, obviously, we don't have good data on that because it's going to be something we look at in the future. This company, however, also did a survey of 800 physicians in 2018. And they said at that time that 69% of those physicians who reported said they would use telehealth, but 77% of that same group said their major concern was that they were not going to get reimbursed. So that was one barrier to us moving towards telehealth previous to COVID-19, is that physicians were resistant to move forward because of the fact that they might not get paid for it. The other was patient adoption. Also, that was another barrier, but this particular study looked at physicians. So what's changed since then? As of March the 6th, 2020, when the CARES Act was signed, now Medicare is our largest health insurance payer in the United States in terms of amount of enrollees. So Medicare put out a statement that they will be paying for telehealth services. So that is changing the tide in terms of physicians feeling comfortable that they will get reimbursed if they provide patient care via telehealth. And it does not just limit it to physicians. Medicare statement also said that they would cover it for nurse practitioners, clinical psychologists, and licensed clinical social workers. So that's important because that changes the mindset of the clinical community. They also said, Medicare said that they are going to allow the provider to either reduce or eliminate copays for telehealth visits. So that hopefully can open it up a little bit more, especially if someone is in one of those populations that Dr. B just talked about, that they do not then have to pay the copay. And with Medicare, it's an 80-20 system. So Medicare pays 80% and the person is responsible for the 20%. The Medicare recipient is responsible for 20%. Many Medicare recipients do have an additional insurance plan, such as AARP, but this is even eliminating that piece if that's what the telehealth is being done. Also, another important component, what Medicare stated, is that they are going to pay the same level as their face-to-face visits. So historically, Medicare has, a different payment for everything under the sun. And so they said, we're not going to pay you any less for telehealth at this point in time during this pandemic versus if you were in the office. And this is a really important thing because what Medicare typically does, other insurance carriers follow. And we have a large group of private insurances or non-Medicare insurances such as Blue Cross Blue Shield, Aetna, and for here in Hawaii, HMSA and Kaiser are two of the big ones. And there are no geographical restrictions for visits. So of course, given the pandemic, you don't have to be living in a rural community and use telehealth. You can obviously be in an urban setting, but because of the stay-at-home orders, etc., Medicare has clearly stated that they will pay for telehealth even if you're not in a rural community. So that's the CARES Act. Then we have to move to HIPAA. So HIPAA is, just to give you some background, HIPAA is an acronym. In healthcare, we like to use acronyms quite a lot. So HIPAA stands for Health Insurance Portability and Accountability Act. This has been around for many years. It became law in 1996. In 2003, because of the use of electronic data and digital data in healthcare, a privacy and security component was added to HIPAA. And at that time, it was focusing on the idea of protected health information. So just to give you some information on HIPAA, it was originally designed to improve the portability of health insurance coverage for employees when they change jobs. But again, it has been added to over time and now looks at fraud and abuse in the healthcare system and in the health insurance system. HIPAA also has the passages that will promote our medical savings account. So if you have a medical savings account that you use through your employer, this was part of that HIPAA legislation from the federal government. Also, HIPAA is also viewed by many experts in health information and other areas that HIPAA was the catalyst, along with another documentation that was released from the Institute of Medicine, but the HIPAA and the Institute of Medicine report on medical errors are kind of the catalyst that led to the HITECH Act. Why is that important? Because the HITECH Act really pushed the envelope for the United States to adopt electronic health records across the nation. So for most of our encounters now here in Hawaii, I know personally that when you go to the physician, your information is being stored in an electronic health record. It's not 100%, but we're probably in the 90% range in terms of EHR adoption in the United States. And part of that is due to the HITECH Act, and the HITECH Act is being identified as being motivated by HIPAA. So HIPAA is an important piece of legislation for our country. So again, HIPAA has some specific privacy restrictions that say you cannot share protected health information. What is protected health information? Protected health information is anything that can lead back to you. So it's your name, your gender perhaps, your social security number, your medical record number if you have one, your health insurance card number. All of those things are protected. So when we share data as clinical health care workers, or when we share data as health information professionals across hospital systems or from one physician to another, we shouldn't be sharing the name of the patient. However, during this pandemic situation, it's important because we need to know where this patient was at, where were their movements, who did they contact. So HIPAA had to be updated to a sense to say, if you are sharing information under this pandemic situation, you're sharing it with first responders, you're sharing it with law enforcement or paramedics or public health officials, you are still protected. You're not violating HIPAA. You won't get in trouble, so to speak, with the federal government. And those circumstances are clearly identified as three things: when the disclosure is needed to provide treatment, when the information is required by law, such as a law enforcement agency, and when information is being given to a public health authority to prevent or control the spread of disease. So that applies to what we are currently living through in COVID-19. They also identified, so the body of our government, our federal government that enforces HIPAA would be the entity that investigates any potential violations of HIPAA would be the Office of Civil Rights, the OCR. So they have also put out some legislation, information, publication that identifies that if a person has tested positive for COVID-19, that if that information is being released to another entity, such as the public health agency of your state, that you are covered in terms of a good faith policy. So if you are in good faith releasing that information with the intent for it to be beneficial, then you would not be in violation and you would be protected by the federal government. This even was discussed a little bit further by Ms. Rita Bowen, who's the Vice President of Privacy and HIM Policy and Education at MRO. So she identified that when we release information as a physical being, a physical organization, we need to know the source. And there should be some type of form or some type of documentation so that there is a trail that you can protect yourself. She used the terminology, a source of truth. So we just don't want to release people's information over the telephone. We don't release information to the media in terms of, we don't tell them who the person is, what their address is, their name, etc. But we can, under the good faith and under the source of truth, identify that we can release that information with confidence to the public health of the state or paramedics, etc., if they need to know that they were exposed to a patient who is COVID-19 positive. So moving into the next part, talking about the more local perhaps or regional legislation, and that has to do with the insurance carriers for the most part. So there's a lot of data out there about the insurance carriers. We have a lot of insurance carriers in the United States. Medicare is the largest one, or CMS, but there's a lot of other ones. There's a really good website called by the Kaiser Family Foundation that identifies all of the carriers in alphabetical order. Most of them are now waiving the cost sharing for COVID treatment, not for testing. This is for if you are diagnosed with COVID-19 and you are being treated for the disease process. 2 states specifically have put in state legislation also to say we are going to cover or waive the cost sharing component. So no more copays, no more deductibles. And those 2 states at this time are Massachusetts and New Mexico. I put the date on this slide because, again, this could change moving forward. It's interesting to note that Hawaii was not listed on that list as of when I looked. Also, there's a listing on the Kaiser Family Foundation website that identifies vaccine. Now, we know there's not a vaccine yet, but a few states have already put into place legislation that identifies when the vaccine becomes available, it will be of no cost to their residents. Those states at this point are Massachusetts, Nevada, Kentucky, Louisiana, and Maine. And hopefully other states will be added to that list because that's a concern that some people, as Dr. B mentioned, those particular populations, they may not get the vaccine if they have to pay for it because they don't have the funds to do so. But if it's a free vaccine, that would be helpful for our particular populations that suffer from health disparities. So this is a snapshot again of some of the health carriers. Again, an individual health carrier in the United States can have their own policy on what they will cover and what they won't cover for anything, including COVID-19 treatment or coronavirus testing. So particular health carriers that I looked at, I tried to look at ones that I knew had a large amount of enrollees, such as Aetna, AmeriHealth, Anthem, Blue Cross Blue Shield, etc. Most of them are going to waive the cost sharing components, which includes copays, deductibles. And Cigna is also going to look at covering the cost of coronavirus testing. So when you go through those drive-through testing stations, if you have Cigna as your health insurance carrier, they will pay for that. And that could be helpful, again, depending on where you are in terms of your health status and your economic status, especially if you are experiencing some type of layoff or furlough situation. In Hawaii, there's a lot of us who are under HMSA. I personally have HMSA, so I was interested to see what they have. And they have a very positively aggressive policy. So they say that they will cover all the diagnostic testing for coronavirus and COVID-19 at no cost. So if you have HMSA and you are paying a deductible or you have some type of copay, you will not have to do that if you are going to get tested. And if you do have to be treated for it, per their website, as of the other day, they're saying that they will cover all treatment and services. So you will not have to pay any deductible, any copay if you have HMSA as your carrier. They also are waiving the pre-authorization. So we know a lot of times your insurance plan will require that you get a pre-authorization from your physician. So again, if you want to go and use one of those drive-up services, if you feel that you have symptoms or you feel that you can get tested, you don't necessarily, from HMSA standpoint, need your physician to sign off on that. And they are also providing some extensions of refilling of medications, again, to help with the chronic disease management. So I specifically, again, looked at this particular insurance company because of personal interest, but I would offer that you should look at your own insurance company and this information should be relatively available at your insurance company's website. Most of them have a banner going right across the top that says COVID-19 information. Kaiser is also doing a no-cost testing, so if you have a copay, but Kaiser does have the fact that you have to still have a referral. So that's an interesting nuance with their particular insurance plan. You can't just go to the drive up if you don't have a referral and hope to get no cost. Again, the cost sharing component would be a copay or a deductible that you have to pay as a enrollee on that particular plan. So I want to open it up for questions, and then I also provided my references and my contact information. One question I have is, what future role or impact do you see contact tracing play in a patient's PHI? Will it be attached to the patient's record or separated? That's a really good question. At this point in time, there's no discussion about that. I'm guessing, and this is an estimate based on my experience, that it will be kept in a state, for the state health department database, so that it would be separated from the patient's hospital record, so to speak. So it would also be, technically it should be separated, or shouldn't be reported, I should say, not separated, but it shouldn't be reported to your insurance carrier. So to avoid any type of bias, perhaps potentially in the future, and again, we don't know, at least from what I've seen clinically, and I'm not a clinical doctor, but we don't know, there's a potential that you could perhaps get this disease process again in the future. We don't know. So we don't want to have any type of, oh, you were a COVID patient, that kind of, you know, bias. So that information should be, your insurance company may know that you were tested for COVID-19. They may even know you were treated, because they obviously got to pay the bill. But there shouldn't be a database that says, okay, we have 25 people in Hawaii, and these are the people's names, address, and phone numbers, and these are the patients that were treated for COVID-19. It should be separated, but it will, again, under PHI and HIPAA, they are at least a public health entity. Again, it has to be an entity that needs the information. The local TV station, no, they're not covered under this. But the public health service, the state public health service, your county public health service would be covered in terms of collecting this data and keeping it in a database. Now, the question I would think of, in addition to what you asked, and again, this is a great question, the question is, how are we going to protect that data moving forward? Because we have to do that. That's our job. We have to make sure that we keep that, and most likely it will be electronic. So my concern would be for hacking and security breaches. And we've already seen that. We've seen the increase in general of hacking and security breaches for everyone, of your personal information, your financial information, et cetera. So if we have these databases of patients who were COVID-19 positive or coronavirus positive, or people that are treated for COVID-19, wherever we keep them, we got to secure them. It looks like another question. What systems are in place to provide telemedicine access for these populations, underserved populations with no access to internet devices, underserved minorities with limited English? There isn't any at this point in time. In terms of what I've seen, especially for the first one, for underserved populations with no access to internet and devices, what is happening is that the community is doing this. So clinicians are going out in vans. They're getting together. They're gathering supplies from a variety of places. They're going out and they're testing. I have not seen yet anyone specifically going out to treat people, such as chronic disease management. But at this point in time, these are two great questions, and they are not being necessarily served. There are, for the people who are, where English is not their first language, there are physicians who have that, they have that skill set, they have different languages that they speak, so they would still be able to perhaps, you know, provide services via telehealth if the physician speaks another language. And typically they keep a list of that. Every network provider, insurance provider, healthcare entity, such as a hospital, will have a listing of their clinical staff and who speaks other languages beyond English. But the issue of access is a tough one, because we do have people who don't have access to internet. And how are they going to get access to it? I know here locally that the one telecommunications company was providing free internet access. But again, you have to sign up for it. But other than actually physically going out into the community and getting to those people that don't have internet, that's the only way that you probably will be able to serve them. But that's going to have to be a part of public health and community focused. Here's another question. I think this is for Dr. B, perhaps? I don't know. This is tangibly related to your topics, but have any public or private policy considerations been made to support the mental health of physicians and first responders who are dealing with this extremely stressful situation? Recent headlines indicate several suicides and healthcare workers who catch the virus. There's no policy that I know. I'll let Dr. B go.
Oh, sorry. Yeah, I was just going to chime in that I haven't heard anything. I think Dr. Rick Custodio gave a talk, I believe it was a Monday or Tuesday. He probably touched on this, so I think there will be links to previous COVID-19 speaker series talks on the library website soon, hopefully. I have not heard any official policy considerations. I spoke to one of my dear friends who is the medical director of the Nanaikeola Kaiser Clinic in Nanakuli on Friday, and he, I asked him how he's doing, and he's still seeing patients mostly by telehealth, but said he was okay. So, but kind of indicated to him, he kind of indicated to me that they were just sort of like chugging through.
And there's no specific, I mean, they would still be covered under, because telehealth allows for social workers and for psychologists to still provide services. So they would still be able to get those services out to physicians and other healthcare workers, but there's no specific policy that's saying any specific, special consideration. Most health insurance, most healthcare entities, hospitals that employ physicians and doctors and nurses, most of them do have an employee assistance program. So I'm assuming that those particular plans, which existed before COVID-19, that those particular entities would still, or avenues would still be there. The issue is getting them access to them, given their schedule, et cetera. But the EAPs, the employee assistance programs, are still there. It's just a matter of having them available to the healthcare workers.
I think we have another question about vaccines in non-injection form, and I want to ask Dr. Gary Roy to address that, since neither Dr. Williamson and I are physicians. Gary.
Impromptu. Hi, everyone. I don't know. I think we have remdesivir that has been touted just this morning as one of our treatments for this illness. And I don't know how that is going to be distributed. I haven't looked up its form, although some forms that are similarly used, like Tamiflu, are in a tablet form. So I am ill-equipped right now to be able to fully answer that particular question, but we have lots of different trials of vaccines. which is a very good thing. And, you know, even looking at femlodipine, which is Pepsid, as something that can be used to treat COVID-19. So there are many things that are in the pipeline, and it's exciting to know. But a lot of them are going to be kind of injectables because, as you would probably guess, an injectable gets to your system the quickest. It gets right into the blood system, and it will be the quickest effect. I'm sorry, I can't give a better answer.
No, you're good. We put you on the spot. I do know, based on just out of interest, because I have a lot of colleagues in this epidemiology area, the University of Pittsburgh is actually looking at a vaccine that will be almost put on like a Band-Aid. So it has an unusual delivery system. I don't know exactly what it is, to be honest. I can't articulate it well.
Yeah, it's a patch.
But it's very non-invasive. And the interesting thing about it is that they were working on it when SARS was in place. So they already had some of the background, groundwork
Excellent.
done. So they just had to ramp it back up. But they are looking at that, and that has already moved forward to FDA approval as of a few weeks ago. So hopefully it will be coming out soon. But again, we have to look at the efficacy, and that, that's a whole nother conversation.
Yeah.
But there are, like you said, a lot of different vaccines out there, or potential vaccines.
Yeah, an intradermal patch would be very convenient if we can ever get something working.
And that particular one, the one from the University of Pittsburgh, and if anyone's interested, I can provide the link to that. There's a great video where they announced it moving it to FDA. It's not temperature controlled, so they don't have to ship it in any type of refrigerated, container. Temperature doesn't impact it, so that's a good thing. And again, they had a lot of the research, not a lot, but they had some of the research done because they had been working on it when SARS was in play 10 years or so ago. So it looks like we have 2 more questions. The coding system has been updated to identify COVID-19 patients. Do you think this data will also be protected? I hope so. We historically now keep information. The good thing about the coding system, our medical coding system, it is de-identified, so the patient's name wouldn't be part of that traditionally. It would just be able to give us once we come out of this, give us some good data on how many patients perhaps actually were treated with COVID-19. And then obviously the thing is that we have to then test more people to get better data on that part of it too. But we can then capture it electronically and say, this is a patient had coronavirus or COVID-19. And then I think the last question we had is, do you think over time the federal government will produce legislation to nationally mandate coverage for COVID-19 treatment? In a way, they've already done so. I mean, they could come down with a mandate saying everybody has to be covered for COVID-19 treatment. At this point in time, CMS, which is the federal government's insurance carrier, for lack of a better word, has already identified that they're going to, at least reduce cost sharing. I think one of the issues, it could happen, but one of the issues for Medicare, at least, is the reimbursement piece. Medicare has already identified it's running out of funding. There's been some discussion about Medicare going away in terms of being there in the future. It certainly could happen given the severity of this situation, especially if you attended Dr. Rick's presentation yesterday. He talked about a second wave and a third wave, and I don't want to scare anyone, but if this doesn't resolve in the next few months and it keeps going on for a longer period of time, I hope that would be a federal government, consideration. The issue is getting all the non-Medicare carriers on board, the Blue Cross Blue Shields, the Aetnas, because they are private entities. So I don't know how they would make a law that would be covering everyone in terms of all non-federal government employees and everybody else, people that don't have CMS or Medicare or Medicaid. That would be the difficult challenge of doing that. They could make a bill that says all Medicare patients have to have coverage. But I don't know if they'll make a bill that will say all insurance carriers, and that the insurance carrier lobby will agree to that. So it looks like we are a little over time. So I think I just want to say thank you for coming today. Again, I deeply appreciate it with everything that's going on and all the information that's out there. I think we just wanted to give you a little bit of a different viewpoint. If you have questions for me, please let me know. Yep.
Okay, bye everybody. Thanks for coming.
Have a good rest of your day. Thanks for coming.